I'm very pleased to introduce Joseph Friedman. I hope he doesn't mind me sharing this, but this is the first event he's doing, work thing he's doing since getting married. So we are very lucky that his new spouse has given up the time for him to be with us. So Joseph is a substance use researcher at UCLA and an MD PhD trainee at the UCLA Center for Social Medicine. He completed his master's degree in public health from the University of Washington, focused on global health metrics, and a data science fellowship at the Institute for Health Metrics and Evaluation. Much of his current research focuses on mixed methods approaches, blending ethnography and data science to measure health inequalities and trace their upstream structural drivers. He has applied these techniques especially to study the North American overdose crisis and track rapidly emerging trends and social inequalities. And I can just say on a personal professional note, I've been reading a lot of Joseph's work and drawn a lot of it from our work. And I think it's really helpful and important for us to be able to look to other jurisdictions, particularly the United States, to help us understand what's happening here in Canada. There are some kinds of data that we don't necessarily have access to and or currently aren't studying here in Canada. And so I hope this this sort of comparison for us sitting mostly in Canada is going to be helpful for the attendees. Thank you, Joseph, for joining us.
Yeah, thanks so much for having me. And I do apologize if this is very US centric. I think a lot of the things that we're seeing in the US do apply to Canada, and I hope we can get into some of the differences, especially in the discussion. So the name of this talk is Far from a White Problem, Addressing the Surging Overdose Crisis as a Racial Justice Issue. I don't have any disclosures of commercial support that are relevant, and I'm a graduate student at UCLA, so that's who's paying me. I will say that this talk does discuss distressing themes such as drug-related deaths and incarceration and racial and ethnic disparities. Just want everyone to have a heads up for that. I'm also going to be using QR codes throughout the talk to link to data and papers. So if anything is interesting and you want to download the article or see where it came from, you can just open your phone camera and grab it that way. So I would say that the overdose crisis is a uniquely American problem. Certainly Canada's up there too, but the US, as of 2019, which is what we're seeing data here. So before the pandemic made everything worse, the US already had an overdose death rate that was double the second highest country and about 20 times the global average. So here you can see the line for the United States. This is death rate per 100,000 from overdose. And you can see the US really broke away from the pack. These are the top 10 countries for drug overdose deaths. The US broke away from the pack in the early 2000s and has just been kind of growing exponentially since then. So we are far and away a true global outlier in this problem. And I think it's safe to say there's really never been anything like what we're seeing in the US, kind of historically, at least that for which we have data. There's also this notion that has become very kind of prevalent in the media, especially, that addiction and overdose are this kind of uniquely white problem. And my co-author and mentor, Helena Hansen, has written prolifically on this topic. So you can see there are all of these headlines with titles like Heroin in Suburbia, a New Face of Addiction. Police say heroin is attracting young, middle-class suburban users. And of course, this is code for white. Some titles are more explicit. They say when a drug epidemic's victims are white. And across the board, there's been this moment over the past 10 years where everyone is talking about the new face of heroin addiction. And this is surprising to people because in their kind of implicit understanding of the world, they associate addiction and drugs with communities of color. And so the fact that this is a kind of white problem, I think this idea has really had a lot of like magnetism in the popular consciousness. It's also very related to this concept of deaths of despair. which has also been racialized from its beginning. So there were two very influential economists, Case and Deaton, Fred Penn, who wrote this article pointing out that midlife, so middle-aged mortality among white individuals was actually rising. And, throughout history, mortality has almost exclusively fallen over time. And so this is kind of a very epidemiologically novel finding. And they looked at the causes of death and that are causing this. And the causes were alcoholic liver disease and suicide, and especially drug overdose was the largest magnitude. And so white America was kind of theorized to be killing itself, either quickly through suicide or more slowly through drugs and alcohol. And this narrative has really kind of centered white suffering as like an unexpected finding. And you can see, I'm sure probably everyone in the audience has heard of this concept. It's on the news all the time. Reporters, say it all the time. It's just something that's kind of now baked into our understanding of the public health of our country. So looking at the actual numbers, right, which I think in some ways support some of these narratives, in many ways don't. Here we can see some data from a recent paper that I just published in the American Journal of Psychiatry, which is available here at this QR code, where you can see total overdose deaths by race and ethnicity in the United States per 100,000 people. You can see back in the early 2000s, overdose death rates for all of these groups were much lower than they are today, and they were all pretty similar to one another with some differences. And in the early 2000s, overdose deaths among white individuals, non-Hispanic white individuals and Native individuals really started to take off, right? And you can see around 2010, the white and Native overdose death rates were about double the Black overdose death rate. And then over the past 10 years, that gap has closed. In 2019, the Black and white rate were identical. And in 2020, the Black overdose death were not shown here, but the Black overdose death rate overtook that of white individuals and is now about 20% higher. So this is the kind of big picture of understanding kind of racial and ethnic trends in overdose deaths. But I think it's important that we dive into a little bit about why the numbers look the way they do. So to kind of take on some of the problems with this white problem narrative, I would say, and I think a lot of scholars have argued, that these narratives have always been incomplete and kind of biased. So first of all, as we just saw, overdose death rates among Native communities were just as high as white or higher, but that really hasn't achieved the same kind of recognition. So for example, everything that Case and Deaton have put out on this topic has simply not looked at overdose death rates or other death rates among Native communities. And so if they're simply excluded, then it kind of doesn't, then they can't be taken into account into this narrative. And so higher death rates among Native communities, I think this is also very important in the Canadian context. And this sort of, throws a wrench into this just so story of this being a white issue. It's also important to note that, the focus has really been on midlife mortality, kind of late 40s, early 50s. And midlife mortality rates are still much higher among Black communities than white, and life expectancy is much lower, right? And if you actually look at, let's say that we take kind of the racism associated with being Black and white, like everything that's baked into that, everything that society exposes you to because you're labeled as Black or white. While it has been true at a certain point that being labeled white has been associated with an increased risk of overdose, the absolute magnitude of what that means for your mortality rate for your life is never been more than 1/10 of what it means to simply be Black, right? In terms of the mortality disadvantage. And so I think it's a little bit dangerous to center white suffering if we're ignoring the fact that really the situation has always been worse for communities of color. And as we're going to see, this kind of momentary higher rate of overdose for white individuals was actually quite short-lived and very small magnitude compared to the other inequalities in our society. But this narrative has been very widespread and has had a lot of power, and actually has shifted some different aspects of drug policy and the war on drugs. And so it's really important context for everything we're going to talk about today. So in order to understand the kind of big picture of overdose trends by different social groups, it's important to understand the distinct moments of the overdose crisis. I'm saying US overdose crisis here because that's really the way I've kind of studied it, but a lot of this really does apply to Canada. So these are the 4 waves, and I like to add a wave 0. This wasn't, there wasn't like an opioid crisis before prescription opioids, but there were a lot of people dying of cocaine. And so you can see here in wave 0, from the year 2000 to 2006, cocaine was the most common substance found in overdose deaths. 2007 to 2013, that shifted to prescription opioids such as OxyContin. 2014 to 2015, it was heroin. And now 2016 to the present, it's been illicit fentanyls. And people kind of define the 4th wave as including a steep rise in stimulants. So again, this is from that same AJP paper that is linked here at the bottom. And you can see a similar picture, but now as the total overdose death trends, but now broken down by substance. You can see trends for all opioids, cocaine, fentanyl and synthetic opioids, heroin, methamphetamine, and prescription opioids. And we can see, looking at kind of across the spectrum of different drugs, there are very unique kind of racial and ethnic signatures to each drug, which we'll get into the reasons for some of these differences a little bit later in the talk. So this was wave 0, right? This is US drug policy and overdose before it was a crisis, that was being talked about in the same way. And of course, we can see that cocaine overdose deaths have always disproportionately affected Black individuals and throughout the full time series. And the dominant response to these overdose deaths was really just mass incarceration and just say no, right? It was sort of abstinence-based, and people who used drugs were really vilified and incarcerated. With the transition to prescription opioids being the kind of dominant factor, we saw a transition to the medicalization of addiction. So instead of addiction being viewed as a criminal problem, it started to be viewed as a health problem, a medical problem. And people who use drugs were humanized in many ways. And you can see that I think many people have critiqued this as because prescription opioids did disproportionately affect white individuals. So here you can see, even through today, but certainly back in the past, the prescription opioid overdose death rate has always been much higher for white and Native communities than for Black. And there are many theories about why this is, but I'm going to present some data here from a paper in 2019. This describes California. And what you can see on the left is a representation of the racial and income breakdown of all overdose deaths in California from 2011 to 2015. So as you move up through the rows of this heat map, you're moving into whiter and whiter zip codes, whiter and whiter kind of very small area units of California. And as you move to the right through the columns, you're moving into higher and higher income parts of California. And you can see here the opioid overdose death rate is very concentrated in low income and white communities. And this kind of classically fits with the sort of dope sick kind of narrative about overdose death rates and who's the most affected, that it's kind of poor white communities. And on the right, you can see the same gradient representing the Society of California, but now we're looking at the opioid prescription prevalence. So this is saying what percent of individuals in these neighborhoods received an opioid prescription through the healthcare system in a given year. And you can see there's a very dramatic gradient here as well. So simply based on race and income, there is a threefold gradient where here in higher, in less white neighborhoods of California, maybe 15 to 20% of people are receiving an opioid, whereas in low income and whiter California, that was almost up to 45, 50%. And I would say this is a fairly unnatural gradient that cannot exist just based on the burden of disease, right? It's certainly not the case that whiter communities had more pain than less white communities, and so something else is going on. And these are from the same study. Now we're looking at benzodiazepine prescription prevalence here on the right, and you can see a very steep gradient. Now, income doesn't seem to be as important. It's just the whiteness of the area. So whiter areas are receiving about 300% more than less white areas. And so really like the racial composition of the neighborhood is the clear driving factor. Here are maps showing these data for the LA metro area. So for those of you who might not be intimately familiar with LA geography, you can see here on the bottom the percent white of each zip code in LA and the per capita income in LA. And of course, LA is a deeply racially segregated city. And so you can see, and money kind of follows this historical and current racial segregation. And you can see very wealthy white parts of LA here kind of around the city center. And if you look at where benzodiazepines and stimulants and also opioids are actually prescribed, this lines up really well. So we're seeing, if you compare Beverly Hills to Compton and Watts, there's a 500% difference. There's a 5-fold difference in the rate at which benzodiazepines are prescribed. I think for stimulants, it's a 10-fold difference. And this is, of course, not based on medical need for these substances. This is just based on access to these substances through the healthcare system, which is filtered through the implicit biases of doctors and access to healthcare. And I think some of this can help us explain why Black communities may have had lower rates of opioid overdose. However, I think it's very important not to celebrate medical racism as a sort of somehow being protective in any way. Again, Black communities' lack of access to high quality healthcare is responsible for far more death than any, perceived benefit from lower rates of addiction. And of course, there's very well documented lack of access to adequate pain control in among African American patients. And so this is a headline that was in the New York Times, a quote, rare case where racial biases protected African Americans. And I'm kind of here to say, I think this is really inappropriate, and we should not celebrate anybody having a lack of access to quality healthcare. There are many instances where people do need access to opioids, and we have to guarantee that, just as we try and reduce rates of substance use disorders in society. So I think a better model for understanding the kind of these differences we see in modern day society and access to medications can be found here in this really good book by David Herzberg, who's a historian, and he writes about how prohibition markets, if you're looking over the long arc of US history, you can see how prohibition markets and medicalized markets have often provided the same drugs to different groups with really different stakes. And so there's many instances now where like almost the identical molecule is given to one group through the healthcare system and another group through a kind of informal street market, but with just really different impacts in terms of safety and incarceration. I also want to directly take on the topic of overprescribing as an issue. I'm sure that's discussed a lot at this conference, and I just want to give my take, which is that overprescribing still kind of dominates the media and policy attention on the opioid overdose crisis. But in my view, it's really one piece of the puzzle. And if you look at the numbers, what we're seeing now in terms of rising overdose deaths is totally disconnected from opioid prescribing through the healthcare system now. Currently, prescription opioids are involved in only 15% of overdose deaths. And if you look at the fraction of those that don't involve fentanyls, it's virtually zero. And so prescription opioids, I think, could be called a distraction from the real issues at this point. There's also a lot of evidence that crackdowns have gone way too far, especially I think in the US context, where a lot of pain and even palliative care patients have been unable to access opioids. It's very well documented that prescribing reductions in the US context have been a very blunt tool, not at all precise, and very racist and classist. So here's a study from 2006 in JAMA Internal Medicine, right as prescription drug monitoring programs were being unrolled. This was in New York, and the state of New York, and they measured which kinds of patients lost access to benzodiazepines as this monitoring system was enrolled. And they categorized those patients by race and ethnicity, and also by like if it was kind of medically appropriate according to the latest guidelines, the conditions that the patients were receiving benzodiazepines for. And they found that the reductions overwhelmingly affected people who are not white, and actually in many cases there's bigger reductions in prescription among patients with like legitimate medical need, however they classified it, relative to those who really didn't perhaps need the benzodiazepines. Now there's a more recent study here, US trends in opioid access among patients with poor prognosis cancer near end of life. This is a patient subgroup who I think we can all agree really should have access to probably as many opioids as are needed to control pain. And yet we're seeing big reductions in their access to pain management, which I cannot help but think is really a kind of a travesty. So moving into wave 2 of the overdose crisis, this is heroin. This was in some ways a much shorter kind of transitional wave. Here we saw that all of that kind of racial difference in terms of overdose death rates went away between white and Black communities. So with heroin, of course, overdose death rates went up, right? Because people were switching from prescription opioids, which are generally a lot safer, have quality controls, to a street-based product, and overdose deaths spiked. And but it did pretty much equally for white and Black communities. And so this is kind of reinforcing that there's something very specific about prescription opioids that has a deeply racialized pattern. Now, with fentanyls, the racial and ethnic gap has actually reversed. So as early as 2018, Black communities were more affected by fentanyl overdose deaths than white. And as I'm sure everyone here knows, the drug supply has just become extremely toxic. And this is the real driving force behind what we're seeing now in terms of death rates. A few details. I realize this is probably a very well-informed audience, but just a few details that I think are key to keep in mind as we're talking about fentanyls. So these are opioid agonists that can be many, many times more potent than heroin, for example, and other opioid agonists. They have a shorter half-life, which can involve more injections per day. And people who I work with, who I do interviews with, talk about this, like all of a sudden they're waking up in the middle of the night needing to use, whereas before with heroin, they could sleep through the night and they perhaps only need to inject like 2 or 3 times a day. Fentanyls were initially concentrated in the Northeast US, but have spread across the rest of the country. Of course, they've also spread to Canada. And they're particularly dangerous because of something called the chocolate chip cookie effect. So fentanyls basically have to be cut or watered down with something because they're so potent. And so tiny particles of fentanyl may not be equally mixed through the different substances that are consumed. And so if you are there's like a large block of fentanyl being cut, and as small samples are pulled off from the larger block, some of those small samples may be way stronger or way less strong, and in kind of a chocolate chip cookie fashion where the fentanyl is the chocolate chip. So, and fentanyl we've seen kind of consistently has disproportionately affected Black and Native communities. So here is actually some nice data from Canada, from Victoria, looking from a paper that was just published, I think a few days ago, linked at the bottom. And they showed the concentration of fentanyl in drug samples that were tested. So here you can see broken down by month. There's like one bar plot here by month. And you can see the really massive range of fentanyl contained in the sample. So although on average, the percent fentanyl is under 10%, or I think this would be the median, you can see that there are samples going up to 30% is still like 20, like a quarter of the samples still had up to 30% fentanyl, which is considerably stronger. And here you can see some crazy outliers where the sample was unexpectedly 60 or 70%. And so it's easy to imagine how someone who's used to getting 10% all of a sudden gets 60%. And this is where an overdose could happen. And then here on the right, we're seeing the average fentanyl concentration by week. And you can see, even though the averages are quite low, it wiggles a lot. And so people are just kind of constantly unsure of what they're going to get on average and in any kind of given instance of buying. The other really defining thing about the kind of fourth wave of the overdose crisis is mixing polysubstance use. So a huge number of people have started using stimulants and opioids together. And this has all kinds of implications for the crisis. But I would actually go further with my definition of wave 4. So instead of just being mixing opioids and stimulants, which has been the focus, I would define it with these 4 characteristics. So driven by illicitly manufactured fentanyls, we've already covered that. Potent synthetic analogs and polysubstance use and counterfeiting. This is really important because it's not just opioids, it's not just stimulants, it's really novel synthetics in a range of drug classes with kind of everything is counterfeit. You almost can't kind of trust anything you buy. There's been extreme exacerbation during the COVID-19 pandemic and sharply rising racial and ethnic disparities. And so this is my definition of what defines kind of the fourth wave of the overdose crisis. So at this point, I want to do a little case study about what I mean by kind of polysubstance use and novel synthetics. So this is some information from a study that we just published about xylazine. Xylazine is a veterinary sedative that was not approved for human consumption because of its dangerous side effect profile. And it was first noticed by an ethnographic team that I work with in Philadelphia in the late 2010s. And this prompted us to then also search nationally for quantitative data about xylazine, which I'm going to present soon. So a lot of the work that I do is ethnographic, meaning kind of long-term qualitative research with people who use drugs. And these quotes all came from people who actually use xylazine in Philadelphia or have been exposed to it. And this helped us understand the potential demand for xylazine. And as I'll mention in a moment, a lot of the things we learned about xylazine really relate to the drug supply in general. So one person said, who's a 30-year-old male who injects opioids and methamphetamine, said, "I like xylazine because fentanyl is such a short-lived high. The nod is over real quick and you get sicker faster. See, the trank," meaning xylazine, "extends the high. It gives the dope more of a heroin-like effect." And this is really key for why people like it. There's also a new risk of soft tissue infection reported by many individuals. So someone said, "I got some friends out here that got really torn up by it. You know, they got holes in them, abscesses. Basically, it's like the body is rotting. People here are losing limbs like with gangrene. Whatever they're doing with trank, everybody is getting these scabby sores all over their bodies." This is actually well documented in the literature from Puerto Rico and other places that have seen xylazine enter the drug supply. And on the topic of risk of overdose, this is from a harm reductionist in Philly who said, "The number of people I was reversing administering naloxone to was definitely going up. There were people who would become only minimally alert and be only slightly responsive to Narcan. So that definitely concerned us that something different was happening, that there were non-opioid agents involved. We did a lot of Narcan training and we had to focus more on the necessity of doing rescue breaths instead of just Narcan." We also looked nationally to see where we could find evidence of xylazine. It's not tracked in any kind of CDC or federal database. And so we actually went coroner by coroner, medical examiner by medical examiner, asking them if they had been finding xylazine. And we got their data and we analyzed it. And we saw that we found presence of xylazine in 10 jurisdictions all over the US, representing all major census regions. And among these 10 jurisdictions, the prevalence rose from about 0.5% of overdose deaths xylazine was found in about 1 in every 200, up to about 7% of overdose deaths. So we're seeing this is kind of starting to take off. And in terms of the geographic pattern, it's following in the footsteps of fentanyl. So it's now high in the Northeast. And if it continues to follow fentanyl, we would expect it to kind of really reach the rest of the country in a more exponential way in the coming years. So what can we learn from xylazine? I think it's a kind of dramatic example because it's this very weird, bizarre substance that's being mixed into the drug supply. But what it shows us is that fentanyl is ushering in this new wave of rapid experimentation with novel synthetic drugs. I think once drugs are already being produced in a lab and not in a field, the dependence on agricultural supply chains is broken and the barrier is lowered to producing all kinds of novel synthetic substances, novel benzodiazepines, cannabinoids, so on and so forth. And we know they're being mixed into the drug supply. And many of these formulations actually have a market advantage due to the short duration of fentanyl. So adding these substances prolongs withdrawal symptoms, it prolongs the euphoria and improves the euphoria of fentanyls. And so people like it, even though they present different health risks, such as overdose that's not responsive to naloxone, soft tissue infections, and many other things. So returning here to this question of rising racial and ethnic disparities, I showed data before through 2019, and here's another graph from another paper that just came out. It's linked here, where you can see again the overdose death rate broken down by race and ethnicity. And we can see that 2020 was a really bad year across the board, but Black and Native overdose death rates are now far higher than white, with something like 30 and 20% for Native and Black communities, higher than white communities, respectively. And I think it's clear that the driving factor here is the increasingly toxic drug supply. So then the question is, why would it be that an unstable drug supply is disproportionately harming minoritized communities? And I think the answer is that instability leads to overdose, right? It takes resources to stay safe in the face of an increasingly dangerous drug supply. And so disparities in things like housing, employment, economic and social conditions, access to healthcare, these have always driven the overdose crisis in North America, and they've always been why low-income communities have been more affected. And we're seeing that they're now driving kind of inequalities for racial and ethnic groups that are more vulnerable. And there's really key inequalities also in access to medications for opioid use disorder and just in access to harm reduction. And I think part of that actually comes back to this like white problem narrative, where I know that there have been actors in harm reduction and kind of social sector actors in Black communities who have at times perhaps not wanted to prioritize harm reduction because maybe this is seen as a white problem. And I think now it's very clear that that's not the case. And of course, we have to talk about incarceration if we're going to talk about drivers of inequalities in overdose. So fentanyl has actually strengthened the risk, the kind of magnitude of which incarceration is a risk factor for overdose. Of course, we know it's always been one, but there's good evidence pointing to the fact that with fentanyl, it's even more deadly. So we see a 130-fold greater risk of overdose in the 2 weeks following incarceration. And this is because incarceration is hugely destabilizing. People leave with very little treatment of their substance use disorder. It's hard to find a job. It's hard to find housing. It's hard to reconnect with people. You've been isolated from your social networks on the outside, and all of a sudden you lose your social networks on the inside. And in this scenario, overdose abounds. And so I think this is just further evidence that there is really no clear benefit of incarceration in terms of overdose risk for people with a substance use disorder. So instead, I would like to think about a kind of spectrum of responses to drug use, right? Drug use is just part of the human condition. And so, we have to decide as a society how to respond to it. So this is a spectrum ranging from extrajudicial killings of people who use drugs, which we're seeing now in the Philippines and historically have been, unfortunately, rather common. Drug-induced homicide charges. So this is basically charging people who use drugs and exchange them with other people who use drugs as murderers. This is now becoming increasingly prevalent in the United States. Prison for simple possession, prison for low-level sales, decriminalization without comprehensive services or with comprehensive health and social services, things like safe supply. So, for example, heroin maintenance programs for people who already have addiction, and then legalization and regulation, which is what we have for alcohol and tobacco and other substances. And to be clear, I think prohibition encompasses all of these options. So even with like very comprehensive decriminalization, like we have in Portugal, where there's good kind of health and social services, of course, the product is still being produced in an illicit market, and all of the kind of violence and instability that comes along with that is maintained, although the end user of the drug might not be incarcerated. And then Oregon has now decriminalized drugs, which I think is great. But the U.S. Oregon does not have a kind of comprehensive welfare system like Portugal, and so there's some question of if there's enough services to come in and kind of replace incarceration as like the main part of the state that's interacting with people. So as we wait to see Oregon's results, we should keep in mind that it's a somewhat limited form of decriminalization relative to what's been done elsewhere. So a note on economic and social inequality. I think we can't understand the very outlier nature of the U.S. overdose crisis without understanding how much of an outlier the U.S. is on other issues related to health and social conditions. Here's a graph from Our World in Data showing life expectancy on the y-axis and health expenditure per capita on the x-axis. And of course, the US is a kind of extreme global outlier in both of these things relative to other wealthy countries, which are shown as the other lines, where we have far higher health expenditure and we get way less back for it in terms of health. And I think the US has a GDP per capita that's like almost identical to Norway. But of course, we distribute the resources very differently. And so it's a wealthy country without a meaningful welfare state. There's extreme inequality. And overdose has always predominated among the lower income parts of the US. And I think, unfortunately, people ask me if I think the overdose crisis is going to get better. And I think the real key, the countries that have really been able to bring down overdose death rates have done it through improving economic, educational, healthcare, and housing conditions more acutely for people who have substance use disorders, but also just for society at large. This is really the key way that we can foster health for people. It's also important to note that some of the other socially bound health problems the US suffers from are very linked to prohibition and the drug crisis. So this is a quote from our field site in Philadelphia from our ethnographic work, and it says, "In our field site, the sale of cocaine and heroin represents an extremely lucrative market located in a deeply impoverished area. In a single day, hundreds of thousands of dollars of untraceable cash routinely flow through a neighborhood where the majority of residents live well below the poverty line. In this context, Tito and Leo after him, two of our informants, needed to be able to perform violence at a moment's notice to protect their reputations and maintain monopoly control of profits. In a clandestine market, there is no legal recourse should product or profit be stolen by an employer or competition. Order, therefore, generally is maintained with violence or the threat of violence." And so I know that there's a lot of people here who are really excited about medications for opioid use disorder and decriminalization and harm reduction, and I am too. I just want to point out that like the core structure that drives so much of the violence in our society is the way we've created this massively lucrative, kind of artificially profitable business, and just and defined that the only way to maintain those profits is through violence. And that is a core problem that I think we have to engage with honestly if we want to improve public health in the United States. So in terms of solutions, as I've just mentioned, we have to start with structural solutions. Well, we have to kind of not lose sight of structural solutions, as I've just been mentioning. But of course, there's also a lot of short-term things that would be really helpful. Harm reduction measures like overdose prevention sites, distributing naloxone and syringes to keep people safe. Drug checking is actually a really key thing and is something I'm really excited about. So here, this is from a drug reporter tweeted about this sample. So this is one sample shown here in this red bag that was tested in Chicago. And this one bag of powder contains Benadryl, multiple fentanyl analogs, xylazine, cocaine, and a bunch of, I think this is a benzodiazepine, right? All kinds of stuff mixed into what was probably just sold as heroin, right? Or just expected to be an opioid combination. And so we're seeing that the drug supply is morphing in all these crazy ways. And one thing we can do about this is actually equipping, instead of trying to, reduce the supply of drugs, which of course has been the dominant approach for the past 50 years and hasn't really worked because drugs are more available than ever, we can actually equip consumers to make responsible choices about the drugs they consume. And one way is through drug checking. So the US just got a national mail-based program. A few locations have these programs where someone can walk in and a tiny sample of their drug will be taken, it'll be tested, and 10 minutes later for free, they'll have an ingredient list, just like in the grocery store, reading the percent fat and sugar and so on. They can read, my drug is 10% fentanyl and 5% heroin and 2% cocaine and 1% xylazine. And this is a way that consumers of drugs can be empowered to actually put market pressure back on sellers and ask for specific things that they want, which is, I think, could be very powerful. And finally, we need to get people onto safer drugs. Canada is far ahead of the US on this topic. In the US, we've been really unable to offer buprenorphine and methadone to people in a cheap way because we have a for-profit healthcare system. So it's extremely expensive, logistically complicated. People have to travel to access these things. And I think it's really time that we consider heroin maintenance programs. There are a lot of people who would be thrilled to be able to find kind of real pharmaceutical grade heroin and get it through a doctor. Not everybody wants a medical model, but for a lot of people who are at very high risk of overdose, getting free heroin twice a day in a medical setting would be a huge increase, a huge improvement, and it would really cut down on their overdose risk. And I think the kind of moral of the story here is that we have to make obtaining safer forms of drugs easier and cheaper and more convenient than getting extremely dangerous forms of fentanyls on the street. So with that, I'm going to end. Here's my Twitter and my email. Please feel free to reach out to me. And pretty much everything that I've presented of my own work today can be accessed here. So thank you very much.
Thank you so much, Joseph. I had high expectations for your talk, but you've exceeded those. I think you gave us a very broad and important overview of, particularly liked your zero wave edition. Important, especially when we think about why did we only start talking about waves with prescription opioids, and I think your answer would be because of its conception as a white problem and something that is therefore deserving of attention. So I think you've given us a really important dimension. In some ways, as we were talking about before, we have pockets of these kinds of data in Canada, but at a national level, we certainly don't. And it's hard for us to discern what some of the racial and therefore other larger social dynamics are at play with respect to the drug poisoning crisis, which we are seeing also experiencing in Canada. I'm going to open it up for any questions for Joseph. We have a good 14, 15 minutes. If you have any questions, if you can put them in the chat. In the meantime, I can certainly I have a lot of questions for you. So your analysis of sort of xylazine, and I saw you sort of linked to what this means as a kind of future for what the drug poisoning crisis might look like in terms of multiple substances, synthetics, and sort of different kinds of markets. And I'm wondering if you can sort of tie that to some of the ethnographic work around and sort of market regulation. How do we need to be thinking in light of xylazine and other synthetics? Does that put even more pressure on initiatives towards legalization and more than, and moving away from prohibition?
Yeah, thank you. It's a really good question. I think that xylazine is it's an easy example to wrap your head around because it is this like totally other drug class, right? So we don't have great data in a lot of ways, but when it comes to something like a different kind of synthetic opioid or a different kind of novel benzodiazepine, it might be easier to just like view it in the same way that we view like what people have been using for a while. But it's actually not the case. I mean, like really the drug supply is morphing in all of these crazy ways. And xylazine shows us that. It's this thing that, arguably just doesn't need to be consumed by humans, period, right? I mean, I would say like even the people who like xylazine, they only like it because it's kind of fixing something they don't like about fentanyl. But those people would probably be way happier with like a longer acting opioid. And so I think like, I hope things are starting to come to a head where, kind of moral debate about whether people should or should not have access to these drugs aside, it's really becoming irrelevant because we've never been able to reduce access to these substances. And so I would hope that, there's been some progress in Canada where people are just saying, like health officials are just saying, yeah, like, look, people are consuming something that's extremely dangerous and they're going to consume it whether we want them to or not. So we simply have to make a legal supply available. There's been like a pendulum in terms of access to opioids that swung back and forth through history. David Herzberg's book kind of gets into this really nicely. And I do think we need to move that needle somewhat slowly. I don't think it would be a good idea. It's clear we went the other way with crackdowns on prescribing like really fast, and it pushed all these people into dangerous situations. That was clearly irresponsible. I think similarly, like we don't want to move the whole situation too far towards just like everybody in society has access to opioids like overnight, right? Like we have to generate kind of like responsible cultural shifts around these substances. And it's clear that we need to, for people who are already using like extremely dangerous street formulations of opioids, they just need a safer option, whatever they'll accept, right? If they'll take buprenorphine, then I think that's a good option for a lot of people. But if not, then I think they should have heroin. They should have like heroin manufacturing. And if they want fentanyl, then fentanyl can be a very safe medication too. And then there's this question of like kind of access for general society, and that's something I think we need to be careful with. But we need to progress from where we are now, because what we're seeing now is just people who are curious about experimentation are basically experimenting with what they think are just pharmaceutical opioids, but are actually fentanyl and novel benzodiazepines. And so the tainted drug supply is becoming an issue that's moving beyond just who we think of like people with already have chaotic substance use disorders and really kind of affecting society at large at this point.
Thank you. And I'm reluctant to ask this question, but I feel like I have to. So we've seen massive investments in addressing, obviously problems with how it's been done, but addressing the overdose crisis in the United States. I mean, just take like the $2 billion that NIH HEAL has delivered just towards research and implementation projects. As one example, what's going to happen if this is no longer perceived as a white problem? What are the dangers? How do we protect against that, and move forward on some of the solutions and interventions that you've suggested, at the same time recognizing that this is disproportionately affecting racialized communities?
Yeah, well, it's a really good question. I mean, the reality is white communities are more affected now than they were before, right? It's just kind of the relative gap. So I would hope that this could be framed as an issue that really is affecting everybody across the board. In addition, I think this is something that Helen and I are writing about now, is like really the goals of the overdose prevention movement now align with the goals of the racial justice movement. And so I would hope that there is growing kind of energy around racial justice in the United States. And I would hope that could, like, really the goals of these movements now align, right? Like improving economic conditions, improving access to healthcare, reducing over-policing, reducing incarceration. There's a lot of synergy. And I would hope that, I think in the best case scenario, this can become like an issue that is understood to be part of racial justice, which it really is, and also economic justice for the country as a whole, without being dragged too far into the kind of like racialized politics of blaming minoritized individuals for the country's woes, which has happened on many occasions.
Mm-hmm. Mm-hmm. Thank you. That's going to be a tricky road to walk, but I think a really, really important one. Not seeing any questions from the audience, so I'm gonna keep at it with you, Joseph, if you don't mind. So one thing that I found particularly striking was your heat maps from LA, looking at opioid analgesic prescribing, and that being telling of issues of access to care based on income and based on race, and that also responses, for example, there's been very wide calls, and you talked about it today also, about increasing access to opioid agonists like buprenorphine, but that such expansions have really favored those who already had access to care. How you've talked about now, okay, we need to think about larger structural approaches, but what do we need to be doing in the health system? Because this seems, it's one interpretation of your data is that it is really the health system that created these racial disparities that we saw through these four different waves. What do we need to be doing different specifically in the health system to respond better, and I think also to prevent these kinds of things in other areas, and also specifically with respect to substances?
Yeah. So I like the model that we have in the US for HIV a lot more than what we've been able to do for substance use disorders, because with HIV, there's guaranteed federal funding for treatment. Of course, there are like important inequalities in HIV too, but if we just had something like that, where, I think with HIV, there was like a similar kind of social rejection of people who had HIV. And then there was this cultural movement where having HIV was humanized, and no longer were people quite as villainized. And then there was federal support, right? It was this battle. It's kind of been not fully won, but that battle's sort of over. We've kind of reached an equilibrium on those issues in a different way than we have with addiction. And I would love to see like federal guaranteed funding for buprenorphine for everyone. I mean, that honestly, like it's just the basics, right? Like that's not a particularly like progressive notion relative to some of the other proposals that I talked about today. It's just like doing the basics right. But that would be transformative. I mean, I know so many people who I've met through my work who are using fentanyl, and if they could really get like an easy, convenient access to buprenorphine, they would. But they simply don't have access. Like there's a ton of barriers, especially if you're not in like a kind of liberal coastal city that has more programs. But even there, people really struggle to get stabilized. So we could just, in the healthcare sector, we could just guarantee the basics, and guaranteeing people like access to primary care that was integrated with like zero cost and like virtually no weight buprenorphine. I mean, that would be transformative.
Yeah, that's often, people have talked about other countries to look at, for example, France, and have talked about mostly that, there's not a lot of training, there's no training requirements, no licensing requirements for buprenorphine prescribing, but they don't talk about the fact that buprenorphine and access to primary care is essentially available, and for other chronic diseases available at no cost. Do you think there's a willingness to think about those kinds of health system reforms in the United States?
Yeah, I mean, I actually think that there's potentially an opportunity to do it for substance use disorders, but like even if we can't do it for just like general health needs, because it is something that is so bipartisan. Like President Trump may announce that the overdose crisis was a public health emergency. I mean, I could see like in the U.S. we're not good at public health, but sometimes we can do these specific carve outs for one issue. And we have that like for dialysis, like guaranteed funding. Like there's certain, and we need that. We need that for substance use disorders. It's not going to be enough, but it would be so helpful. And yeah, just doing the basics right would be a massive improvement over what we have now.
Wonderful. Thank you. We're going to have to leave it there. Thank you so much for joining us, Joseph. Please follow Joseph on Twitter and read his papers. I'm sure a lot more important, provocative, informative research is going to be coming from Joseph and his teams. Thank you so much.
Thank you very much.